So good afternoon. What I thought I'd do today is do an overview because we've had some questions about the acute care residency here at Emory University, and I thought this would be kind of fun to share. This afternoon, I have Dr. Keely Collins on with me, and she's our most recent graduate of our program, and she's going to share some insights also. I'll stop at each slide and see if she has any other comments, but I also introduced some of the research that she did at the end of her residency, so I wanted to share that. When we talk about the Emory University Acute Care Residency, it's really based on that we have a program mission as well as program goals, similar to other residencies. The idea is that we're going to prepare you with advanced knowledge and skills in the area of acute care physical therapy practice. We're going to provide you with a solid foundation of application for evidence base. We're going to prepare you to be critical consumers of that relative scientific information. So what's happening? What have we learned through COVID? What have we learned through other pandemics? What have we learned through different things that we've experienced in the intensive care unit, and look at it linked to literature. And we're committed to prepare physical therapists for engagement in clinical, academic, professional teaching, as well as consulting ability through their residency and thereafter their residency. The goals is we're going to try and make you the best prepared acute care therapist for critical thinking that we can. So I'm not going to read through all these, but that's what I really want you to think, how we use the acute care residency as a stepping stone for you to be that outstanding leader in acute care. We really have four main components of the acute care residency. We focus on teaching and mentoring, research and mentoring, clinical and mentoring, as well as didactic and discussions through that mentoring. So for the research and mentoring, it's going to have an acute care focus, but it's really decided between you and maybe the clinical partner what you want to focus that research on, because you do it over your time as a resident. We want you to think about how will it add value back to the practice in acute care setting. The teaching and mentoring, you become part of the Emory University faculty and help us in different courses so that you can then apply things that you learn, and we help you become a teacher. So we have you go through a 14-hour session. It's called Teach the Teacher Boot Camp to help you kind of start thinking about what does it take to be a teacher. The clinical and mentoring, we have two clinical partner sites. One is Emory University Midtown Hospital, and one is Emory University Hospital. And both of them are academic teaching centers, but with a little bit of different focus. You'll be doing 3 different rotations at each of those facilities. So you get a real wide breadth of clinical experience and practice, as well as mentoring with the mentors that have that different higher level of skill, depending on what area of practice within acute care. Under the didactic, we have you participate in the Neurologic Physical Therapy Consortium for Education, the PT Cardiopulmonary Educators for their advanced program. We offer orthopedic lectures that are through our program that with our orthopedic residency. So you work with the orthopedic residency and faculty there. It's on pain science, it may be on diagnostic, but you do it in partnership with our residency. We want you involved in a monthly journal club, the Teach the Teacher Boot Camp, which again, you work with residents and fellows that are not just from Emory, but they are now from University of Alabama. They're from Duke University, they're from Mercer University, and they're from the Children's Healthcare of Atlanta, both their fellowship as well as their residency program. We want you to go to combined section meetings so that you can network. You can also have updated educational opportunities at combined sections. And we want you to participate in the Johns Hopkins Hospital Critical Care Conference. We feel that's a really good foundation because you will be experiencing critical care while you're going through your residency. Dr. Collins, did you want to add anything to that information?
I think in terms of the didactic portion, when I first came on and I was looking at the didactic portion, I was very overwhelmed with it. But I will say that it's throughout the year is very paced at a good pace. So it was never overwhelming when I was actually in the residency, but looking at this, it can be very overwhelming, but it's also matched up with when you're going to want it during your residency. So you're not looking at intense cardiopulm didactic work when you're not really on your cardiopulm rotation. And so, or same thing with oncology, that didactic stuff kind of comes when you're going to see more patients who are diagnosed with cancer. And so it really is questions that you're going to have when you're seeing these and treating these patients. And then you already have the resources that are given to you to kind of help answer those questions and then absolutely apply them. And then I will say the conferences, for the Johns Hopkins, it was online for me, and so I still have access to those resources. And I've had some coworkers go and also attend that conference, and it's a huge utilization for critical care. And then the same thing with CSM is that you can go and you can choose which courses you want to go to, so you have freedom with that. And so what I kind of did is I found areas that I still needed more work in with the didactic, and then I had the choice to go to them. So you still have a lot of autonomy when you're looking at the didactic portion, and all the mentors really kind of pull in and are also willing to learn from that didactic portion as well.
Can I ask you a couple of questions? So when you're looking at this and trying to figure out, what does it mean to have the clinical portion or a teaching or didactic, how did you kind of get your hands around that so you didn't feel so overwhelmed at the beginning of your residency?
I think I was very schedule oriented. I really wanted to have my weekends, and I really wanted to have social events that, if my friend was getting married, I didn't want to be stressed about residency during those eventful periods of their life or my life. And so I really looked at, okay, what areas of this year do I know I'm not going to be doing a lot of residency stuff? So what areas of the year do I have to be focused on residency? And I think that was very doable to find that it's not going to be consistent throughout the year. You're not going to sit down every Monday and be like, I'm going to do 4 hours of didactic work tonight. You could. I never followed that, so I didn't do that. But I will say the schedule itself gives you time throughout your day to do didactic. So some days I would be 4 hours clinical, 4 hours didactic, or 2 hours didactic, 2 hours research. And so the schedule itself is very flexible to allow you to set time aside during an actual work day, an 8-hour day, to do it. So it wasn't really that stressed. The way that I kind of say was, it's the time during your first year of PT school going into your second where you figured out how to get your schedule together, and you just have to do the work. But it's not ever overwhelming where you feel like you can't have a life during it. And then I will say, with it being one resident, that also was in a favor too. There were many times where I would talk to Kathleen and be like, hey, this week, I'm going to be honest, I was focused on clinical this week. And it was a mental health week for me. I didn't get these 2 webinars done. And she's like, oh, okay, we'll push it back. And then it was very flexible with that because she understood that life happens. And it's nice to have one resident where it is flexible with it. But there are times where she's like, okay, you have your midterm coming up. It's on this date. Get ready for it. So there are times where you being flexible but not taking advantage of that flexibility and making sure you're staying on top of it. And then you have those weekly or bi-weekly check-ins with your mentors who are like, how's your didactic stuff going? Where are you on this? To make sure that you're not falling below where you need to be.
So Dr. Collins, can I talk to one thing that you brought up? We mentioned the monthly journal club, and you talked about being the only acute care resident. What did the journal club provide you with that you couldn't get being the only acute care resident here at Emory?
I think there were pros and cons to being a single resident, right? So you have the pros of the flexibility and the one-on-one mentoringship and the lack of, oh, she's doing this or he's doing this, I also have to be doing this. So there was not that there ever was in the program, but there was never competition in that sense where I should be there by now because they're here by now. But you also kind of lose someone who's in your shoes checking in on you, if that makes sense. So the journal club allowed you to find another acute care resident or numerous other acute care residents who are in the same shoe as you and understand what you're going through. And we had times during journal club where we'd sit and just be like, how are we all doing? And so we kind of checked in with each other in that sense. And then you still have the other residents from Emory University. So I would check in with the neuro residents often. I would check in with the orthopedic resident because, again, they had a single resident that year as well. So we kind of talked about how there are pros and cons to being a single resident, but I never felt unsupported or quote unquote like alone in the residency, because you have all these other resources, and then the networking at the conferences really help too.
And then just to go with that, I mentioned about the Teach the Teacher boot camp would expose you to other residents or fellows in the area. Was that something that you also found as a networking opportunity?
Oh, absolutely. So the CHOA resident and I, we actually got really close. There was a PT and OT fellow, and we did a lot of the cases together because we all kind of brought in a different mindset too. I brought the more acute PT for adults, and they had the more pediatric idea, and then the OT also was always there to bring in their perspective. And it was very interesting on how we would view different cases completely different. Or same with the ortho. So the ortho resident and I shared a case, and it's funny how we kind of came with two different mindsets, but I learned so much presenting on the ortho case, and she learned a lot presenting on the acute care case. So it is kind of interesting that we all share the PT mind, but we come in now that we're looking at the patients in a different light. So it was kind of interesting to talk and network with them. And I still talk to them all the time too.
Cool. And I see, Nia, that you've joined us. Did you have any questions at this point in the presentation that you'd just like to ask either myself or Dr. Collins?
Not right now. I was just enjoying listening to it. I just wanted to hop on just to hear if anyone else had any questions, but
okay.
All the questions that you've asked, Dr. Bishop, I've been wondering too. So thank you.
Well, cool. Well, let's just go to what does the application process look like? So, and I think Dr. Collins, you can speak to this also because you've been through this and you were hired on as our acute care resident. It says 3 letters of recommendation, and instead in a bullet point here, strongly recommend at least one clinical instructor from your acute care rotation to kind of write that supportive. How did you make that happen for yourself?
I did reach out to my acute care long term. So the one I did my rotation out in St. Louis. And so I reached out to her, and she was more than willing to write me a recommendation, and was actually very interested in the residency itself because when she graduated, she didn't have a residency. So we just chatted about the residency. And then I also reached out to, and it was interesting. So with her, because it's been a while, because it was my first rotation. And so we kind of got on a Zoom call, and she was like, how are you? And we just got to know. So it was a great kind of check in on her and check in with my CI, because she's like, sometimes you lose contact with them. And then I believe I had one of my other CIs from Arizona. I believe he wrote me a recommendation to kind of look at though it was outpatient, the rotation that I was on was half outpatient, half wound care, and we did have some acute moments. And so I had him reach out, and I thought it was important to have one that was in acute care, but also with this residency being so big on other aspects of their continuum of care. So you have oncology, you have ortho, you have neuro, you have all these other aspects of your didactic that I thought it was beneficial to have. And I recommend having a CI from another setting can kind of show off your skills from that other setting, because I still use my ortho skills all the time. The other day I did a Dix Hall Pike on a patient to diagnose them with BBPV, or strongly correlate them with BBPV. And so you don't lose it. If you want to use it, you can in the setting. And so I think it's definitely beneficial to have someone a patient or a person who's able to really see your skills and can kind of brag about you. It's a similar idea that for any job, you want someone who will brag just as much about yourself that you can.
Yeah. Well, thank you for sharing that. Now, I know one of the requirements is that you have to pass your boards before the residency start. Was that any challenge for you? Either did you do your boards in April or did you do your boards in July?
So I did my boards in April, and I will say a lot of my class did their boards in April because of the way the world was at that point with COVID. There wasn't much going on. So we were all like, let's just sit and cipher our boards and do it. And I did like it because if they didn't go so well, I could sit for them again before in July. Luckily that did not happen, and we passed the first time. So that was a win, and I could just kind of focus on getting ready for residency. But I will say it's the decision for April and July boards is completely individual. I think if you are taking a lot of electives, which again, like during our time, they weren't very stressful electives. I got the ones I was interested in, but I wasn't taking a ton. And the other courses I felt comfortable doing it.
Mm-hmm.
And so if you don't have any other life happening or anything like that, then you feel comfortable taking them in April, then go for it. But you don't absolutely need to do it. And I know during your third year, you should be soaking that time up in PT school and not be worried about your boards. So I don't think there's any pros or cons to taking them in April, taking them in July. Again, it didn't affect my start date. So if I took them earlier.
And one of the things I've highlighted on this slide is strongly encouraged. So I put an elective on there, the advanced elective in acute care. Is that something you took or didn't take during your third year?
I did not take it. I took and there was a reason why I didn't. So I didn't take it because I knew I was taking the oncology elective, and I knew I wanted to go into an oncology. The last spring, you go into clinical, and I knew I wanted to do an acute care clinical. So I knew I was going to get some type of acute care experience in that last semester. But I also didn't, to be honest, I wasn't 100% sure that I wanted to go into acute care. So I also wanted to make sure, and I also didn't know if I was going to get a job in acute care during my third year. So then I also wanted to take dry needling in case I went outpatient right after. So I wanted to kind of keep that in mind. So I did not do the advanced acute care, but you did offer us time, or a small section of students, to do the ACLS certification who did not take that course. And I don't know if that's still an option or not. Yeah. And so I did do that, and I highly, highly, highly recommend doing that, even if the acute care residency is not something that you want to go, but you want to do acute care. That certification, though you may not use it every day, because you most likely will not use it every day, did help you understand. Yeah, fingers crossed you don't. But it helps you understand medications, helps you understand the process of basically running a code. And so when you see that in a chart and you're reading about it, you understand what happened, and you can understand the gravity of that situation. So when you go and you treat that patient, probably the next day in acute care, let's be honest, you can have respect for what that patient had just gone through that previous day.
Well, thank you. So the requirements are that for our program, we have to go, everything is uploaded through what's called RFPT-CAS. So if you apply to DPT programs, you do it through PT-CAS, but for the residency and fellowship, it's done through RFPT-CAS. The opening of the enrollment started on December 1st, and I've now extended it to toward the end of February. We actually are starting doing interviews on the 14th of February for candidates that have completed all of their documentation and uploaded, and then we've reviewed their files to say that these are a candidate that we want to interview. The interview process, it's a panel interview. We have representatives from both of the clinical sites that we rotate to. We also involve Dr. Krishnan, who is the kind of our research coordinator. We invite either of the other two residency directors, so either Dr. Geis or Dr. Zajac Cox, to be on it. Dr. Sharp is on it. Again, kind of a well-rounded panel where we go back and forth and ask questions. At the end of that, we ask that you do a 15-minute presentation to us, kind of like that you would do on poster day. So you would do a presentation that relates why, showing us your critical thinking, showing us your clinical decision-making, how you involve evidence, and then why would you shine from that point forward as an acute care resident. So once that process is done, the panel does meet. We accumulate all of the summation of all the comments and grading of the interview, and then we make a decision and we send out an acceptance letter. And the acceptance letter, you have a 24 to 48 hour period to sign that letter to say, yes, this is what I want to do. But with it, we ask for a commitment of $500 to say, yes, I want to do this. And that goes towards your full tuition. It's not like it's in addition to it. The acute care residency is a 12-month cycle. We start August 1st and go through July 31st, or right in that range. We don't make you come on the weekends to start if it's on an off day. You have to complete 1,500 hours at a minimum of clinical exposure. And again, as Dr. Collins says, she's going to spend six months at Emory Midtown and 6 months at Emory University Hospital. 300 hours are combined, both teaching, mentoring, and research. And then we ask that both for the clinical component as well as the clinical competency, you have to pass at 80% and above, the midterm and that final for didactic, and also demonstrate clinical competence. We partner with the American Physical Therapy Association, and we use their clinical competence form, which really says, kind of like how much assistance, how independent you are. And it has big categories related to what a resident should be doing, both clinical, clinical decision-making, patient care, and so on and so forth. Dr. Collins, would you add anything with that?
I think, yes, I was going to say something. Okay, so with the tuition, I was going to say that in terms of, that is something that I was very concerned about. I was like, and I'll be very candid about it. I put myself through PT school, and I did not want to end up taking out anything else after PT school. And so I was very nervous about the financial aspect of going into this residency. And what I realized was that the tuition that you're paying, you are getting it's not, exactly where it's going to. So it's paying for your conferences that you're going to. It's paying for both CSM and both Johns Hopkins. It's paying for Neuro Consortium, and it's paying for the cardiopulmonary didactic. All of those, just those 4 things, are pretty much the majority of the tuition in terms of when you pay for it. And you see it, you talk right there, you see the price of everything. And to me, that made me feel better, because then I was like, okay, like what I'm paying for is making sense. It's helping me become a better resident. But also, that being said, you still have the full benefits that you would have a full-time employee. And so you don't necessarily need to worry about any of that situation happening. Like, I went and kept all my doctors pretty much the same. My dentist, all of that was very easy, because you got to take care of yourself throughout this year. And then with that, the salary that you do get paid is absolutely doable to live off of. So I was living in Midtown in Atlanta with one roommate, and it was definitely, you got to sit with your budget at the beginning of the year and just look at it, but it's doable. And I think that's one thing that made me feel a little bit more comfortable going into it, was that I knew I didn't have to take out anything else, and that I was able to fully support myself on this salary. And again, if you're coming out of school, I'm going to be honest, any salary is more than what you're getting right now. So it is definitely, it's nerve-wracking to see that tuition, because I don't know if a lot of people knew that you have to pay that tuition. And if you didn't really know that, it is kind of a hold on, what's going on here. But you can do it. It's a very clear where it's going, and that it is going right to you and to your residency.
Well, thank you.
I do have a question about that. Mm-hmm. So I know with like the whole like loan pause that's been going on for just like student loans, I don't think you had to do this, but in general, do you know if that gets prolonged anymore after residency ends? Like, are you still considered a student to where you don't have to pay loans like right away after like you graduate the residency?
So I personally did not I didn't do that, because again, like you said, it was on loan. I know I did talk to the orthopedic resident, and she ended up doing that. So she did register herself technically as a student, as like an extra year of learning, and they can pause it for your payments for that sense. So I do believe it's possible. I did not do it, but if down the road that's something you need to, I have someone to put you in contact who did do that. I will also say the tuition that you're paying is, let me use the right term. You put it on your tax return to get something back.
You get a tax deduction because of it.
Tax deduction, yes, thank you. Oh, I sounded intelligent there. I'm good with finances. No, but so Kathy Crosby's really good about keeping that. And so when your taxes are due, you have her send you a letter, and then you submit that as well. So you get money back for your tuition, because it's bettering your education. So I will say, I believe you can pause your loans with a residency, because someone previously did it, but I don't want to confirm that because I did not do that. But
I don't know if you can, and just I'll speak on the other side of it. I don't know if you can, because you're actually getting paid as an employee. So you may not, and I'm not, maybe she did something special, I'm not sure, but I would not say absolute without talking to your accountant or talking to someone who knows taxes, whether you can defer those student loans until after your residency. So because you're an employee, you are receiving a taxable salary. And so I'm not sure. So that's definitely something you'd want to check out.
Also, though, if you are repaying your loans, you can do the one that's based off your salary. So you're not paying that, like that price that you're seeing right now. And I forget there's a better way to say it than the one that's based off your salary. But they basically, you submit your salary and it will set your loan amount that you have to repay based off that. So it should not be like you're not going to be, half your salary should not be going to your loan, basically.
Correct.
So sorry to confirm, we don't have a set answer, but I have people that we can ask.
She's got people.
No, that's perfect. Yeah, thank you.
So one of the things I do want to share, Nia, is that it's an expectation of our program, and that's unique about Emory, is that you do complete a research project. And Dr. Corden Whitlock now, Dr. Whitlock, she was our first resident, and this is the study she did, is she looked at interdisciplinary early mobility in the 11 ICU at Emory Midtown, and she looked at the AMPAC and correlations to discharge from that intensive care unit and barriers for physical therapy and early mobility, and then changes in those AMPAC scores. So we do have that expectation that you will go on and do some project. And Dr. Whitlock went on and published this result in the American Physical Therapy Journal, in the Physical Therapy Journey. So definitely impressive and then this is Dr. Collins, and again the expectation is Dr. Collins will then, she's actually presenting this information at combined sections. She got accepted to do a platform there, and then Emory program is helping with registration or something because she's going as a representative from the residency program. Dr. Collins, do you want to speak to your presentation?
Sure. So basically what I did is I focused on an oncology population. And I was able to tag team with another study from the Winship Cancer Institute and utilize their database to see how PT was utilized with this population. So as individuals who are diagnosed with renal cell carcinoma who underwent surgical resection for the renal cell carcinoma. And basically what we did is we used 3 or 4 major outcome measures, 3 of which were given to me. So we used the frailty scale, we use the Charleston comorbidity scale, and the ECOG, which are all were all done pre-op. And then what I did is I went in and saw if these patients had a physical therapy order, if they were seen by physical therapy after an evaluation, and how many treatment sessions were done. And so for that, I then did a pre and a post AMPAC score for the patients who had PT. And so with those kind of 4 functional outcomes, we looked at the relationship between the utilization of physical therapy with specific frailty scores, ECOG scores, and comorbidity scores. We looked at their functional mobility from their PT evaluation to the time of discharge with the AMPAC, and then we looked at readmission rates. And so overall, we kind of just got an idea of how physical therapy is utilized within this patient population. And I started this right at Midtown, and I carried it throughout the whole year. But you had the support of the staff both at Midtown and Emory University Hospital. And then I did have some support from the Winship Cancer Institute. And then obviously the side of the School of Medicine supported me with this as well.
Nia, any additional questions?
I don't think so. You guys have been very thorough.
We planned just for you to be really thorough.
She made a PowerPoint. I didn't even have a PowerPoint ready. She was like, I have a PowerPoint. I'm like, of course you do.
Oh, well. Yeah,
well, it was just great. Kind of an easy way to map it out and then ask you questions off of it and ask like your journey with that as a framework. So, and then Nia, there are probably, I think it's the country is up to 10 acute care residencies now. They're on the East Coast here. They're up in Chicago and out west and down in Texas. So they are around the country. So again, if you're thinking about cost of living and You should think about what's going to be best for me to balance my work life and still continue growing in acute care. I do want to say the acute care residency isn't to replace an acute care clinical. It's to take you to that next level from what you started with one of your long terms or your GMC ICE. It's to take you to that higher level. And I just want to make sure you know that.
Right. I did have one more question. You guys might have gone over it before, but I didn't catch it. So there's not a board exam to sit for an acute care residency, right?
Correct. That
Okay, but
2 years out.
Wait, I'm sorry, what was that?
It's probably 2 years out.
Oh, where it will be required?
Not required. A board exam is not required of any residency. It's a choice the resident makes when they finish the residency. They have kind of like this expedited way to be able to sit for their board, but it's not necessary. Okay. I mean, it's up to the individual when they finish their residency and what they do with that information.
Okay, that makes sense. Okay, so when people have like a cardiopulm certification, that's just like from continuing ed?
No, so Dr. Sharp and I and Dr. Whitlock and possibly in the future, Dr. Collins, a cardiovascular and pulm board certification is through the APTA. And we didn't, at my time, there wasn't a residency. Dr. Sharp, there was only like 1 or 2 residencies in the country. And so I actually mentored her to prepare her for her boards. You don't have to have a residency to sit for the boards. If you go through a residency, it kind of expedites you in preparation to sit for the boards, because that whole year, it's like a preparation for a board exam. I think you bring up a great point, Nia, that, well, how do you make a decision if you want to be a board certified specialist? Then maybe you want to think about a cardiopulm specialty, but what can you do in the acute care residency experience? So Dr. Collins, can you speak to how it helped you get your position at the hospital system?
I think going into it, I know I previously mentioned that probably 3rd year PT school, I was still a little undecided if I wanted to do acute care or if there was the rumor that you kind of had to, it was at the time kind of harder to get a job in acute care, like a full-time right off the bat. And so I was still a little trying to figure my life out. And so what I thought about was going to an acute care versus cardiopulm, was that I didn't know if I fully wanted to go into cardio. As you can tell, I did my research on oncology, and now I'm sitting on the main cardiac floor, and that just kind of happened to be where I ended up. Those were the patients that I loved treating the most. But I think the one thing that I liked about the acute care residency is that you got neuro, you got oncology, you got ortho, you got cardiopulm. And so you were able to kind of figure out, what patients do you prefer to treat? What patients do you not feel as confident treating? Mm-hmm. But one thing that I realize now is that with the patient population that I currently work with, I probably bring in more neuro than I did when I was on neuro. Or I bring in, and I have a lot of my counterparts asking me like, how should I progress this? What am I doing here? Or if a lot of them are neuro patients, like their main diagnosis that we're focusing on is now, unfortunately, a stroke, then they'll come and talk to me about certain interventions. And I think that's really cool. They've been practicing on the cardiac floor for ranging from like 3 to 10 years. And they're coming to me a year out asking, what do you think we should do with this patient? So I think that was something that I am glad that I did, because I truly still don't know what board exam I'd want to sit for. I think with the acute care one coming out could be a great opportunity. But I also, if I stick with cardio and I still love cardio, then I could sit for the cardio. I know Kathleen has said maybe I could do both, and I'm going to stop that right now. but no, I will say that I think it is one of those that you lose. You sat through PT school where you learned about a ton of these patient populations. And I think when you come out, it's very easy to get closed-minded on this one patient in front of you where you're only focused on, oh, they came in with congestive heart failure, I'm only going to look at their heart. Or they came in with AFib, I'm only going to look at their heart. Well, AFib, if it's uncontrolled, they're prone to a stroke. They easily could have a stroke. And now you're looking at a patient who just had a recent stroke. And so I think it's one of those situations where you can't just look at the patient in front of you. You have to look at the whole picture. And I think the residency taught me how to do that, and then taught me how to prioritize their treatments. So a lot of the time I'll prioritize neuro interventions over cardiac interventions in the cardiac ICU. Or I'll use my education for cancer-related fatigue and cancer-related pain in the neuro ICU. And so I think it's one of those things that it allows you to hit that next level and provide better care for your patients, where you feel confident with the information that you're doing, the information that you're teaching them, but you're also pushing yourself to not be closed-minded. I think it's kind of fun when I do it, because now, though the patient might be having a very similar surgery, I'm treating them completely different in 2 separate rooms because of their past medical history or their life. And I don't think that I would have been able to do that. Actually, I know I would not have been able to do that without the mentorship or coming right out of PT school.
So Dr. Collins, can I ask you 2 questions?
Mm-hmm.
I see that you have a lot of mentoring. Can you just give maybe an example of how a mentoring session goes to help me better understand the difference between a clinical instructor and a student versus a practicing therapist that's getting mentored as a resident?
They're so fun. No, they actually are. That sounded sarcastic. They actually are really, I enjoy them. Because you can kind of, in a way, it's fun because they're learning from you just as much as you're learning from them. And I think that's what makes mentoring more fun than a CI student relationship, because I think with a CI student relationship, there is that kind of dynamic of, let me show you this, or you can learn from me with that idea. While mentoring, it's a very balanced and almost a conversation of, you're kind of tag teaming this patient, this session, where there's sometimes where my mentor might do the majority of the treating, or towards the end, I'll do the majority of the treating. And then you look at a patient, you chart review. Sometimes we'll spend the majority of the time just looking at the chart. Sometimes we spend the majority of the time with the patient, and sometimes we spend the majority of our time just talking about how the session went, or we sit down and we write the note together to make your documentation stronger. So really the mentoring sessions are what you need. So if you can follow the patient, I know there's one time I sat with my mentor probably for half the mentoring session, which ranged about 2 to 3 hours, just looking at the chart and looking at medications, because that was one thing at that time I did not feel confident with. Or we looked at why they came in and how did that make sense, or what is this presentation like? What could we do during the intervention? So that's interesting, because you normally can't take that much time on a chart review in the acute care setting. So the residency allows you to take that time. And then with the actual patient, you guys go together, you treat the patient or you eval the patient. And majority of the time, if it's you're starting off on that rotation, I was never afraid to say, could you take the lead on this mentoring session? So I can kind of do more of a learning. And then towards the end, really you're running the mentoring session, like a treatment session. And then you and your mentor go and kind of debrief. So you go through the ICF model, and you just basically kind of talk about what you did, what interventions you prioritize. You talk about very acute care things like line management. You talk about what you're planning to do next, and then discharge planning, all of that. And then you can go and you write your notes. So all of that time is built into your day. So it's not like you have a full caseload and then you have 3 hours of mentoring. You have 3 hours of mentoring and then a 5-hour caseload. So it comes out to an 8-hour day. And so I think that was one of the cooler things with it, because towards the end of each rotation, the mentors will ask you, like, why'd you do that? And then you explain it and they're like, oh yeah, that's kind of cool. Okay, yeah. And so they're learning, like, it's definitely a conversation towards the end of residency, while in the beginning, you still have that kind of student mindset coming in, where I was always a nervous student, where I was like, I don't want to mess up in front of them. That'd be embarrassing. And then there were plenty of times where I messed up and my mentors were like, I did the same thing. So it was my mentors were never scary to work with, or they never were trying to break me down. They never were intimidating. They were always like, across the board, very supportive and all very different. And so I thought that was really cool, where I learned something so different from each mentor. And I think there are times where I'm like, oh, that's such a, I was treating a patient today and I saw one of my old mentors and I was like, I pulled a U today when I was treating them. And I was like, that's such a gym move. And he's a great mentor over at Emory University Hospital. But then I'll like text one of my mentors, like, I had this patient that was just like this one. And my mentors will text me back from like Midtown. And I still like get dinner with my Midtown mentors. So they're all very willing to learn, and honestly very like they chill. They understand the stress that comes with residency, and none of them are trying to add to that stress with it.
Cool. And the second thing I'll probably end with is, did you feel supported during your residency?
100%. Absolutely. In terms of like, honestly, any aspects of whether it was teaching, I don't like, there are some times where I was very nervous teaching a certain thing, because I was like, what if I'm not the best teacher? What if I'm saying something, they have no idea what I'm talking about, and then I'm taking their time away from an important lesson in their curriculum. So I was always nervous about teaching. There are times where I was very nervous about these bigger evaluations where you came in and to watch us, and it's a more intense evaluation, make sure that you're kind of hitting the marks. But it was never nerves where I felt like I wasn't going to do, like that I wasn't going to succeed. Because there were times where I was like, what if I do fail? And you're like, well, figure it out. It's okay. You're supposed to. You're not supposed to be perfect right off the bat. If I was, I wouldn't need to do the residency, and I still am not. And like towards the end, you're not supposed to hit 100% on everything. That's why it's set to 80, because you're not. And so I think that's something that I like realized that I was okay with, that I wasn't going to be 100%. I'm like, I don't think no one will ever be 100%. So I do think I felt supported in terms of trying to do my best and making sure that I was doing my best and not slacking off. But then in terms of like life, for sure happened for me during my residency. My dad got very sick. And I felt, in terms of my mental health, super supportive with my check-ins. My mentors knew, and I made sure that, they all made sure that I was taking care of myself first, and making sure that I felt the support from both clinical side, didactic side, and every bi-monthly check-in. Bi-monthly? Yeah, bi-monthly check-in. It was always, how are you? Never, what are you doing? Like, it was always gently asking how I was doing. And I think that was something that helped me throughout residency, where I never really had a full breakdown, I don't think. I cried.
Yeah.
Towards the end, but I was also, but if that happened, it was like, okay, what can we do to be okay? But it was never like I can't do this. I'm done. I'm giving up. I never felt that.
Well, thank you for sharing. Nia, I think I've asked some questions, but do you have anything else?
I think you've hit them all. Yeah, thank you guys for presenting and giving me some information. I still don't know exactly what I want to do, and I haven't done like a full acute care, even like ICE. I was in inpatient rehab for the one after GMC, but I'm in an outpatient like hospital-based clinic right now, and one Saturday a month we have to do acute care. So I'm kind of getting like tiptoeing into it a little bit, and then my next TCE is all inpatient acute care. So
I think that's a
I'm
nice
excited.
way of getting exposed to it, Nia, is like once a month, and you're going in with your clinical instructor, and it's just it's a nice way of easing into it. I like that.
Yeah.
And I will say the residency itself is set up like that too. So you start at Midtown, and then you go to Emory University Hospital. So you do the 6 and 6 months. But the first rotation, you're just on, it's pretty much a floor gen med rotation, where the most lines you have are an IV and a nasal cannula, maybe a wound vac, maybe a Foley. And so it eases yourself and just like, okay, I'm back in the hospital, doing my subjective, working with discharge planning, working with my transfers, like very basic stuff like that. And then you go kind of more, you go to neuro next, but it's a lighter neuro. You start with the floor, and then my mentor is really good about being like, okay, you let me know when we want to start the ICU. So probably about like 2 weeks into the floor, I was like, okay, let's start. And she came with me until I was ready to go by myself. And then, so I started like very little ICU. Again, it was the neuro ICU, so it wasn't a lot of lines or anything like that. And then you went to probably one of the more invasive ICUs at Midtown was the Peachtree ICU, which is the head and neck unit where you have a lot of JP drains. A lot of these patients are trached for airway protection from their surgery. So then you kind of get like, that's when you're really focused on line management. You're focused on communicating with a patient who is nonverbal. And again, my mentor is really good at talking about that. And we still laugh at the one patient she said she was going to check me off on. She's like, so these surgeries, they go back to like one flap. So like an area of their body that had the graft somewhere. She's like, you'll never see a patient that has like 4 or 5 grafts from one surgery. Chart reviewing my patient that she's going to check me off on. This patient had 4 or 5 grafts from one surgery, and I go in and I'm reading her, kind of presenting the case to her, and she's like, no, what was the most recent surgery? Not the history of surgeries. What's the most recent one? I go, nope, that's the surgery. And she's like, okay, well, if you can do this one, you can do any of them. And so it was like, but anyways, we like tag teamed it together. And so that was the one that was like very big on, okay, line management, focus on that. Your first kind of really good ICU, big ICU. And then, so it kind of works your way up from like a floor to an ICU. And then when you go to Emory University Hospital, you kind of reset. So again, you start on the floor, and the neuro is more intense though. So the patient populations are kind of more intense, where you're focused more on just getting comfortable with the new hospital, comfortable with the new staff. And so they kind of lead you in. Again, they come with you to the ICU, make sure you feel comfortable. And then for each rotation, they kind of do that same setup where you're now, like by that time, you're feeling good with the ICU, you're feeling good with acute care, but they'll still will go with you, orient you to the floor, orient you to the ICU, orient you to the nursing staff, get all of that set up so it's not just like throwing you in there. But in terms of gaining your confidence in acute care, the first 6 months, that's pretty much its job, is to make sure you feel confident just in that setting. And it slowly increases. So you start gaining your confidence. And I believe that's intentional, is it not?
It is. It's called scaffolding. Yes.
There you go.
So setting you up for success.
Yes. I will say the question that I've talked to other students about is pretty much anyone will ask me is if I would do it again or if I see the benefit of it now. And I say yes every time, because I do think that it got me where I am now with my job, but it also allowed me to gain my confidence with it and allow me to keep an aspect of research in my career, an aspect of teaching in my career, an aspect of clinical. And so I think that's something that you get with residency. Obviously, it's heavy on the clinical, but you still have the aspects of teaching, the aspects of research that carry on after residency too. And I don't think I would have had those same opportunities if I didn't do this residency. I also don't think I could have the conversation that I have with my colleagues now if I didn't do the residency.
Well, you probably mentioned this at the very beginning, but where do you work now?
I did not mention that actually, so great question. Oh. I'm at Emory University Hospital now in Atlanta, and I am working on mainly the cardiac ICU and the step-down units there. I talked with my supervisor, and I was like, because I did this residency, I'm more than happy to float to other floors that when they're low staffed, if they need it. And so, for example, when I transitioned in this role, neuro was super low staffed. And so I would stay on neuro probably half the week, where I was still doing neuro floor and neuro ICU. And right now, over at the tower, it's kind of low staffed with oncology patients. So I go over there sometimes too. Mm-hmm. So my main, I'm under the cardiac floor and cardiac unit, but I'm never surprised if I come in and my manager's like, so you're neuro today, which I love that aspect, but that's not necessarily because they don't rotate at that hospital. So at Emory Midtown, they do rotate. So the therapist will I want to say every 3 months, they rotate floors.
Something like that.
3 months. They rotate floors. So they were covering the whole hospital. While at Emory University Hospital, they don't rotate floors. So you stay on your floor. And I think there's pros and cons to both. But I did want to hold on to the other skills that I learned, kind of what I was talking about, that, I want to hold on to the skills that I got from the whole residency. My manager was super supportive with that. And so she's also still asked me, she's like, if you want to stop loading when you want to, just let me know. But technically full time, I'm on the cardiac ICU.
Any other questions, Nia?
I don't think so. Thank you all so much.
And Nia, just, we went ahead and recorded this, so it's going to be posted we got a couple of people reached out from their clinicals that they said they couldn't attend. And I hope that's okay, that we will be posting this for other students to see.
Oh yeah, that's fine.
And then Nia, if you have any other questions or anything like that, feel free to email me, or anyone, I guess, can email me if they watch the recording. Kathy Lee has my email, both my personal and my work email. I check them both. I don't care which one you use. Or if you want to set up a Zoom call, just you and me, I'm happy to do that. Let me know. It doesn't even have to be about the residency. If you just need to chat with someone who was more recently in your shoes, we can chat. So
thank you.
just let me know.
Okay,